do I mean by renal clearance value, or RCV? The units of renal clearance values are milliliters per minute. But what does that mean? Clearance is a general concept that describes the rate at which substances are removed or cleared from the plasma. Renal clearance of a substance is the volume of plasma completely cleansed or cleared of a substance in a given amount of time by the kidneys. For example, let's take antibiotics. Do they last in your body? Do they last indefinitely? Why do you have to take an antibiotic every 4 to 6 hours or every day? Because the antibiotic is dissolved in the plasma, and the plasma will be cleansed of it. You want to keep taking that medicine over and over again, obviously, to kill off the bacteria. If you don't take it on a regular basis, your kidneys are going to effectively cleanse it from your body. That means that any resistant bacteria will have more opportunity to replicate and grow in you. That is basically what we mean by renal clearance. It is the amount of plasma cleansed per unit of time, a minute, let's say, of a particular substance. In this case, it could be the antibiotic. Calculating renal clearance values for a particular substance is very useful in a clinical setting. I will show you the calculation on slide 13. We calculate renal clearance values for any particular substance. We calculate renal clearance for an antibiotic, for example. We basically collect the urine over a certain amount of time, say a 24-hour urine sample. We have a urine flow rate, which is represented here as V. We can measure whatever substance we are interested in. U subscript S represents the concentration of some substance that you're monitoring in the urine. We divide the product of urine flow rate, V, and urine concentration of the substance, US, by the plasma concentration of the substance, which is here as P subscript S. We're basically asking, what do we get in the urine, and how much divided by what we started with in the first place of that substance in the plasma. When we do that simple math, we actually get a value of milliliters per minute of plasma that has been cleansed of a particular substance. Let's put the big concepts together. It takes time for a substance that is only filtered to be completely cleared from the body. We can imagine that it would take several passes of plasma through the kidneys to completely remove that substance from our body. That meaning it's only filtered and not secreted. We have 594 milliliters per minute of plasma arriving in our glomeruli, but only 125 milliliters per minute of that plasma volume gets into Bowman's capsule along with whatever substances are dissolved in it. That means that 469 milliliters per minute of plasma with that substance dissolved in it did not get cleansed, filtered. It is going to pass out of the kidney. It needs to recirculate to the body and come back again and again and again. What is the advantage of calculating the renal clearance of a substance that is only filtered and nothing else? Here I begin telling you why this is advantageous. If we are playing with a substance that is neither reabsorbed nor secreted, we can actually use that substance to determine a patient's glomerular filtration rate. Again, to reiterate this, a patient's GFR tells us a lot about their renal health, and that's the focus of this chapter. A patient that doesn't have a good filtration rate is not filtering his or her plasma. That means he or she is not removing wastes effectively. A person with a compromised GFR is going to be in some stage of renal failure. Let's explore this concept further. If you are looking at this slide, you will see an equation for excretion. Whatever is excreted from the body is dependent on if it was filtered and how much, plus its secretion rate, minus whatever amount was reabsorbed. Notice that if we are playing with a substance that is only filtered, that means that the secretion of that substance and reabsorption of that substance does not apply. Our equation is reduced to something much, much more simple. Whatever is filtered ends up in the urine. The filtration of that substance is going to equal the excretion of that substance from the body. Let's see how we can apply this. Inulin is a polysaccharide. It is a type of storage form of carbohydrate in plants. We are not capable of digesting it. It cannot be reabsorbed by the kidneys nor secreted. Inulin is a substance that we can use to calculate GFR. If we introduce it into the patient's bloodstream, it will be filtered. Whatever is filtered will be excreted. Let's pursue this on a clinical aspect. How can we use inulin to actually determine a person's GFR? Let me lead you through this step by step. First, like I said, we can't digest inulin. If we are going to use it as a way to assess a patient's kidney function, then we will need to inject it into their blood. We have the patient come to the hospital and we inject a known amount of inulin. Once we have infused the inulin into the patient's blood, we then draw a sample of blood from the patient. You can think of the patient as being injected with the inulin, have them stand up and jump up and down to mix it in their blood. I'm being facetious, of course. Then we draw the blood sample. We want to see what the concentration of the inulin is in the plasma once it has been equally distributed. Next, we obtain a urine sample from the patient. We actually collect a urine sample of over a certain amount of time. So we're waiting for the inulin to be cleared from the plasma. If we collect it over a certain amount of time, we know how much urine flow they've created. It tells us how much urine the patient has released from his or her body during this time. That is our urine flow rate. We can also measure the amount of inulin that comes out in that urine. It is, of course, a substance that is freely filtered, and therefore we can calculate the amount of inulin excreted in that urine. We can collect a sample of, say, 6 liters of urine in 2.5 hours. That is a flow rate. We can measure the amount of inulin in that urine. We can get a unit of milligrams per milliliters. That's the inulin that's dissolved in the urine. If we multiply those two things, that will be our excretion. So it's urine flow rate times the urine concentration of inulin. We know how many milligrams per milliliter of inulin was voided from that individual at the end of calculating using this equation. Let's take this to the next step. We've injected the inulin. We took the blood sample. We've obtained urine samples and determined the amount of inulin in the urine. Now we can simply solve for the patient's glomerular filtration rate. Look at this slide. The amount of inulin that was filtered has to equal the amount of inulin that was excreted, because inulin is filtered but not reabsorbed and not secreted. So whatever is filtered will come out in the pee. How do we calculate how much inulin was filtered? How do we calculate filtered load? I showed you in a previous slide that filtered load is GFR times the plasma concentration of inulin. It has to equal what was excreted in the urine. How do we determine excretion rate? It's the amount of urine collected in an amount of time, urine flow rate, times the concentration of the solute in the urine. That gives excretion rate. If you look at this equation, GFR times the plasma concentration of the solute equals urine flow rate times the urine concentration of the solute. 3 of those 4 values can be easily measured in a clinical laboratory. We can measure the amount of inulin in the plasma. We can draw the blood, put the blood in the spectrophotometer, and we can measure the amount of inulin per milliliters in the blood. Can we collect urine? Yes, we can collect it over a length of time. That is flow rate. We can measure that. Can we take some of that urine and measure the amount of inulin in it? Yes, we can. That is the urine concentration of inulin. That's in milligrams per minute. So if we rearrange this equation, GFR times the plasma concentration equals urine flow rate times the urine concentration, we know 3 of the 4 values. We can solve for the last remaining value, GFR. So GFR equals urine flow rate times the urine amount of inulin, or the inulin in the urine, divided by the plasma concentration of inulin. That will give us GFR. And if you look carefully at that equation, that is also the equation for renal clearance values. The amount of plasma per minute of time that is cleansed of inulin is going to end up in the urine. It is a reflection of GFR. We can use a patient's clearance values for inulin to determine their GFR. You probably need a way to test this. You need an example. A doctor suspects a patient has kidney damage. She injects inulin into the patient's vein and then removes some blood and determines the inulin concentration. She also collects urine over a given amount of time, and she measures the amount of inulin in the urine. If we simply plug and chug our plasma value of inulin and divide it into the urine flow rate times the urine concentration of inulin, then we can actually calculate the patient's GFR. Again, GFR is an assessment of renal health. In this case, the patient has a GFR of 120 milliliters per minute. That is very close to the calculated 125 milliliters per minute that I was just telling you about. According to the National Kidney Foundation, a person who has a GFR of 90 or greater is a person with stage 1 kidney damage. So I hate to tell you this, all of us are in stage 1 renal failure. Isn't that weird to think about? When you get to stage 5 renal failure, that means that you have a GFR of 15 milliliters per minute or less. That is really bad. That is about a tenth of what you should be at, roughly. That is end-stage renal failure. Now I'm going to tell you how a person can get to renal failure in just a minute. But I want you to know that after age 30, every 10 years, 10% of your renal function declines. So if you are 40 years old, you already have 10% of your kidneys failing. If you want to think of it that way, if you want to think of it that way, if at all, when you get to age 50, then 20% of your kidneys are not functioning correctly. So every 10 years, you have 10% of your renal function declining. I want to reiterate that if a substance is freely filtered, but not reabsorbed nor secreted, then we can use that substance to determine a patient's glomerular filtration rate. This really tells us how well the kidneys are filtering the blood. That is what this really means. We can use inulin, a carbohydrate that needs to be injected, but we can also use creatinine. Creatinine is an endogenous byproduct of muscle metabolism. It does not require that the patient come in and get infused with inulin. We simply can measure the amount of creatinine in the blood and measure the amount of creatinine in the urine. When you go in for a well person checkup, what do you always have to do? They take a fasting blood draw, right? They also have you pee in a cup. When you get your lab results back, you might notice that they have calculated your GFR using creatinine. You didn't have to get injected with inulin. They are merely comparing the amount of creatinine in your blood to the amount of creatinine that is being excreted in your urine. If you have very little creatinine in the urine, but high amounts in the blood, this is an indication that your kidneys are not filtering it appropriately, and that is an indication of renal failure. It should be noted, however, that a small amount of creatinine is secreted, which means it is not as good a measure of renal clearance, or GFR, as when you use inulin. But we can actually adjust our results in the clinical laboratory for this slight secretion. What I mean to say is that when we use creatinine to assess a patient's GFR, the results will be a slight overestimation of GFR. Again, we can do an adjustment in our calculation for that. Blood urea nitrogen, or BUN, can also be used to measure GFR. BUN is a product of protein metabolism. If a person is on a high-protein diet, then their BUN would be elevated, and the amount of urea ending up in the urine would also be high. So we don't really want to use blood urea nitrogen and urea in the urine as a way to measure GFR, but we could if we were hard-pressed. What is renal failure? Renal failure basically means that your GFR is compromised in some way. Now, there can be pre-renal problems, which means that something is happening before your blood even gets to the kidneys. Problems can also be intrinsic or interrenal. The most common cause of pre-renal renal failure is hypovolemic issues. This is where GFR is compromised. How? Low blood pressure, hypovolemic issues from hemorrhaging or dehydration, anaphylactic shock, or blood pressure dropping for other reasons are examples. If you are not getting adequate blood flow to the kidneys, they are not going to be able to filter appropriately. You can even have a staph infection destroy your glomerulus, or have glomerular nephritis where the glomeruli are being lost. All of those are considered to be pre-renal issues where you are not getting appropriate GFR. Other ways to get renal failure are intrinsic ways, which means they happen within the kidney, the nephron. For example, pyelonephritis is a general term to say there is a dysfunction anywhere in the kidney, specifically the nephron, the pyramids, the calyces, even down to the ureters. You can have a problem with the ureter having too many calcium deposits. All of that can be a result of pyelonephritis. If the ureters fail, for example, because of calcium or any blockage, you can literally have filtrate damming all the way back up to Bowman's capsule. This would disrupt the Starling forces that we learned about a few lectures ago, and that would impede filtration. So that's our general explanation for renal failure and considering pre-renal versus interrenal issues. What are some signs of renal failure? Well, this would include polyuria. If solutes are not being reabsorbed appropriately, they stay within the nephron, and that could lead to increased urine output. That's polyuria. Azotemia, emia means in the blood. This is now referring to the accumulating nitrogen products in the blood, like ammonia, creatinine, and urea. This can happen from decreased GFR. As I said, this is going to lead to high nitrogen content in the blood. Blood urea nitrogen is going to go up. The patient would also have a high serum creatinine. Why could a patient also have anemia with renal failure? The anemia could be from a lack of erythropoietin. If the kidneys are not able to release erythropoietin appropriately, then red blood cell synthesis can slow or even be halted. How can there be hypertension? Well, if there is a problem with GFR from low blood pressure, the hypertension may occur as a result of the RAA system, the renin-angiotensin II aldosterone feedback mechanism, and that would lead to increased blood pressure. Or if the kidneys are not able to filter the blood appropriately and remove waste products, the water content in the blood can build up in that case. In which case there would not be, in that example, polyuria. Then that might lead to oliguria, which means no urine output. So you can really see the broad spectrum of problems that can arise with renal failure. You can have too much fluid retention because you're not filtering, and that can lead to hypertension. Patients who have renal failure are more susceptible to infections because the elevated nitrates in the blood, the azotemia, will actually destroy the T and B cells. So that's part of the reason why they are more susceptible to infections. All right, that concludes our general lecture for renal failure.